everyone! Since you're in the comfort of your own homes, listening to this online science forum, instead of being at the lecture hall of the College of Development and Communication, we are indeed learning in difficult times. But learn we must and learn we shall. This science forum, entitled Pagmamatyag, a multidisciplinary discussion on epidemiology in the time of COVID-19, was designed to deepen our understanding and appreciation of epidemiology and its role in decision-making and taking action for public health. Three panelists will lead our discussion: Dr. Enrique A. Tayag, from the perspective of public health; Dr. Emmanuel M. Luna, from the social science standpoint; and Dr. Jomar M. Rabajante, from the data science and mathematical modeling perspective. We hope that this discussion will allow us to recognize that now, more than ever, we have to work together. And now, more than ever, we must communicate science. I would like to congratulate the Department of Science Communication, led by its chair, Assistant Professor Elaine Llarena, for spearheading this event. I also express my deepest thanks to the faculty and staff of the College of Development Communication who helped organize this event. So again, welcome to this year's first Science Forum.
Our second speaker is actually Dr. Jomar Rabajante. So Doc Jomar is a professor and UP scientist at the Institute of Mathematical Sciences and Physics, University of the Philippines, Los Baños. He holds an appointment as junior associate at the Abdus Salam International Center for Theoretical Physics in Trieste, Italy. He is also the chair of the Diploma in Mathematics Teaching Program at the Faculty of Education of UP Open University. Dr. Jomar is one of the ASEAN's science diplomats. He obtained his Doctor of Science degree in Mathematical and Systems Engineering, major in Environment and Energy Systems from Shizuoka University, Japan, as a Japanese government Monbushu Scholar. His Master of Science in Applied Mathematics, major in Mathematics and Life and Physical Sciences, he graduated from the University of the Philippines, Diliman, as a DOST scholar, and he finished his Bachelor of Science in Applied Mathematics from UPLB. He was a visiting professor at the Biology Department of Carleton University in Canada, visiting researcher at the Max Planck Institute for Evolutionary Biology in Germany, and visiting scientist at the Fields Institute for Research and Mathematical Sciences in Canada. He attended research schools on mathematical epidemiology at Imperial College London and on systems biology at Ohio State University. So let us now listen to Dr. Jomar Rabajante.
Okay, thank you very much. Good afternoon. I'm going to share my screen for my presentation. Okay, so my presentation actually will focus more on what we are doing with the UP COVID-19 pandemic response team, specifically from my team, the UPLB Biomathematics Initiative. So to give you a brief background, UP COVID-19 pandemic response team is composed of hundreds of scientists, social scientists, economists, mathematical modelers, from the UP system, from Baguio down to Davao. And with this team, we have different subgroups, and one of the subgroup there is the one UP NCOV modeling team, which I am part of. So let me start first my discussion this afternoon by talking about mathematical modeling in the sense that what is the goal of what we are doing. So somehow we can use mathematical modeling to get some idea or insights from what happened in the past and to know some patterns that can uh, characterize our present and to somehow give us idea on what could possibly happen in the future or what are the events that we don't want to happen in the future, such as the worst case scenarios. And in modeling, we actually cannot really understand everything, okay? Usually modeling only gives us a certain portion of the event or of the scenario or of the system. In this case, the COVID-19 pandemic. And with this perspective, even mathematical modelers can provide different lenses, okay, when we look at this problem. So one mathematical modeler would focus on one part of COVID-19, another one would focus on another one, and they could have different perspectives, but the good thing here is when we combine everything, when we integrate everything, and when we compare the results, if there are differences or similarities, we can somehow um, get a good idea what the problem is, a good idea what the problem is all about. Okay, I've done many talks on mathematical modeling, especially the mathematical side, but here what I'm going to share to you is more on the concepts, specifically on how my team, the UPLB Biomathematics team, is modeling the COVID-19 disease. Just to give you some disclaimer, our modeling team is an independent team. The government, the IATF and DOH, they have their own modeling team under the data analytics sub-TWG. Okay, so what I'm going to show you or to share to you is mostly based on the perspective of my team. So when my team, the biomath team, is analyzing the COVID-19 pandemic, we look at the whole possible story, the storyline of the epidemic, of this COVID-19 epidemic. So when we analyze this, we start first with the establishment stage of the epidemic. Okay, this is very important because we know different places in the Philippines, we might have different establishment period or establishment time. And there are some provinces that until now, they don't have cases, and some provinces that already have many cases. So in an epidemic, if you have an imported case there, it doesn't mean that there is a 100% probability that there will be an outbreak. Usually at the establishment stage or the outbreak initiation phase, there could be some random effects, or somehow our preventive measures can stop the occurrence of the outbreak. And in here, one of the things that we put as a metric is what we call as the local outbreak threshold. And this local outbreak threshold somehow gives us idea how many imported cases can have, let's say, 90% chance of kicking the epidemic to the exponential phase. Okay? So that's the outbreak initiation phase. Okay, and also Dr. Tayag gave a very nice lecture on the epidemiology, and one of the things that he said there is that we also need to have an event surveillance, in the sense that we can also track the possible clustering of cases, let's say per sitio, per barangay, or per certain establishment like jail or prison or malls. Okay, so that's also one of the metrics that we can look at. Okay, and then at the second phase of the epidemics, let's say we were not able to stop the initiation of the of COVID-19, there's a possibility that the epidemic will go to the exponential phase. And with this exponential phase, we need immediate, effective, and efficient interventions, because we are not just talking linear dynamics, but exponential. The number of cases will multiply very fast. And definitely, because we are talking about exponential, one metric that we can use there is what we call as the doubling time, to track the speed of the outbreak. And another metric that probably you have heard many times in the media is the reproduction number. This is one of the measures of contagiousness of the disease, but this is dependent on the setting, okay, on a certain setting. And this reproduction number provides us a measure on the average number of people that an infected individual can directly infect. Okay, so, and I'm going to show you some of our computations regarding the time-varying reproduction number. And another important thing is definitely when we are in the epidemic, there should be a public information awareness efforts. And we could somehow get some metric on how effective our information campaigns are. Okay, and after the exponential phase, we might have some level of interventions. In our case, we have the community quarantine. In other countries, this might be very strict, really a strict lockdown. And one of the measures that we need to look at this stage is the local healthcare occupancy rate, because when the number of cases will go above our healthcare capacity, okay, and definitely our healthcare capacity might be at the start is not ready for the epidemic, so we need to increase our capacity. Then there could be some people here that were not given optimal care, and probably also leads to the increase in expired cases. So with this one, we based on the Pueyo's article, we call this the hammering or the buying time phase. Then after this, when we already prepared our healthcare capacity, our testing capacity, our contact tracing efforts, then we can go now with the dance phase, okay? And in this dance phase, what also we need to look at, definitely we still need to have the doubling time, the reproduction number, etc. But we can also look at the positivity rate to track how our testing efforts are being increased, because the formula for positivity rate is the number of people getting positive over the number of people being tested. So if you want to lower the positivity rate, you need to look at the numerator, which means the number of people getting positive is going down, or another one is the denominator is expanding. It means we are also expanding our testing capacity. And also in the dance phase, we need to look at the social and economic recovery efforts, and we can also give their compute there some metrics. Okay, and for now it might be very early to talk about this, but there's also another phase here, which is the vaccination phase, where we are going to put some to track herd immunity based on vaccination, not based on natural infection, but based on vaccination. We need to compute the herd immunity level, and there are some formula to compute for this. Okay, and definitely there are many metrics that we are looking at. I'm not going to talk about them one by one, but the main idea here is we need to, as what Dr. Eric told us, we need to learn from this epidemic so that we can have future-ready policies and infrastructure and system after this COVID-19. So currently, the metrics being used, of course, there are many metrics being used by the government, but if you look at the media, most of the things that we see there is the critical care utilization rate and the case doubling time. And from there, I don't know if this is still the metrics being used by IATF, but previously they used this metric to uh, decide if a certain province or region will be under ECQ, MECQ, GCQ, etc. Okay, and there's also the National Task Force zoning stages based on municipality or barangay, if whether you are in the critical zone, containment zone, buffer zone, outside buffer zone, etc., etc. But this is based mostly on prevalence of actual active cases in a certain locality. Okay, now going back to this system or framework that we are using in the biomathematics team, there can be many alarm systems that we can use. And what we are proposing here is we should not just focus on one metric because a certain metric has a disadvantage, but combining all metrics can provide us a clearer picture of the situation of the epidemics in our country. To give you some idea on what we have done, I think I need to show you first the website of the ncov.ph. Okay, and we have the dashboards here. If you've accessed this one before, so I think you have already seen that there are many features with this ncov. Also, just to give you a disclaimer, the government has its own official dashboard, the COVID tracker in the DOH website, and also for the different LGUs, the government rolled out the PASTER dashboard, but definitely that can only be used by LGUs and official institutions. But for the public, that's why we created the ncov.ph. So the public can somehow get some analysis, epidemiological analysis, based on the DOH data drop data sets. So we have here the time varying reproductive number, the case fatality ratio, crude recovery rate, confirmed cases, etc. So you can look at the different graphs here. Okay. The time varying reproduction number here is very important because somehow this could give us an idea on the level of the outbreak, and the threshold here is 1. If R is greater than 1, it means somehow we are near the danger of outbreak. But if R is below 1, somehow we are at the good side. But definitely, we cannot just use R as one metric, okay? Because R has also disadvantages. But this is one of the things that we have here, the reproductive number. And you can also look at the reproductive number, not just in the national level, but also up to the municipal level. Just click the epidemic curves link here. The UPLB biomathematics team also created our own dashboard. Okay, so and you can get the link later. And with this dashboard, we created this because we want to have a specific perspective on what's happening, specifically with regards to genders specific data, like disaggregating the data, male, female, like this. Okay, the cumulative, and also per health status, how many are asymptomatic, mild, recovered, not just currently, but to look at that trend temporally. Okay, and of course with the pie charts here, and also age distributed per health status, and by gender, and if the female is pregnant, etc. Okay, and also time frame here, the depth of death, the date of death, the date of recovery, etc. And the mean days from death from onset. Let's say a certain COVID-19 positive individual had an onset in a certain date. On the average, and if that person will be an expired case later on the average, how many days it will take that person to die. So we also have that here, and also for recovery. And not just that, we can also look at the distribution per region here. The ncov.ph also has this feature. Okay. And another one, we also did a data tracking on the delays. Let's say how long a certain how long would the result from the test to be confirmed from the onset date. So on the average, the number of delay is around 14 days, and we have here the distribution. And also there are other data here. Another one, the delays in reporting deaths. So what's the delay from the confirmation of death up to the reporting of that death? So here is around 17 days, etc. So we also have that here. Another one is based also on DOH database. We also have the utilization rate of the ICUs, hospital beds, etc. The DOH tracker also has this, but here we plotted temporally through time. So everything you can see here, and the location of the hospitals, the bed wards, the ICUs, the mechanical ventilator availability all over the country. Another one is we also, what happened? Okay, what happened to my browser? Okay, there. So we also computed some metrics for different provinces like Bataan. This is the time varying reproduction number for Bataan. Okay, and then you can check there temporally, and the doubling time for Bataan. So we also have that. And also we are also tracking the testing data, how many tests have been conducted. So we are already are nearly 450,000 tests. How many unique individuals have been tested, how many are already positive. But of course, this number here might include duplicates. Okay. Daily output. Okay. Test conducted, daily output, unique individuals tested. So here, this is June 7, it's 8,000. How many people in June 7 got positive results, etc. And also we are tracking the backlog. This is the validation backlog. June 7, we have 3,000 backlog result validation. And of course, later on with this one, we also computed the overall positivity rate of our testing efforts. And we also computed the R, the reproduction number, based on the testing results, normalized. We normalized this based on the increasing testing, because we want to check to eliminate the effect of increasing testing on the possible increase in the number of positive cases. So we also have that here, and also the doubling time, etc. So that's the dashboard. And we also created a platform, a decision tool for job risk profiling, and we profiled almost 1,000 jobs, and we combined them through based on sectors. So we have that here. You can look at your job here and what job is riskier. And we also created a calculator for you to see. And we, in this first type of calculator, you just search your job. Let's say you are an actuary. Okay, then from the calculation, you would get that your job, let's say, is have a 0.37 risk score, which means you have low risk. But if your job is not here, or you don't agree with this computation, because the jobs here are preloaded, we have an open calculator that actually many companies are already using our calculator. They have consulted with us. So you can click here the number of encounters per hour that you, let's say, on the average, you encounter 3 people per hour, etc. So you need to also click the work shift duration. Let's say you work 8 hours a day, the crowd density, how how dense is your workplace area, then the protection level. Then this calculator can compute your overall risk score and the risk type. And we have some ideas here that giving you some perspectives on how to compute some metrics with this calculator. We also, in this, anyway, I'll show that later. We also have a website showing the projections since April 6th, because we want our projection to be as fast or faster than the virus. We have already released some of our projections to help our LGUs to compute the outbreak threshold per provinces. Okay, and then we also have there for the whole country up to the barangay level. Okay. So also we have here for the region 4 some estimates with the peaks, possible peaks, etc. But of course, these have some disclaimers, because as we put interventions, the dynamics will change. Okay, and our models are uploaded here for open, to make it open, to make it transparent. So we have that in this website. And to somehow, before I end, I'll just show you some simulations. So we have here one of our simulations to compute for, this is for the outbreak threshold, but this one is for, you can see the Excel file, right? So here, this is for workplace COVID-19 outbreak threshold and transmission microsimulation. So if you are in a certain workplace, you input there how many employees you have, the number of floors, office type floors, the number of interaction. Then you can have the output here to compute for the outbreak threshold with 90% probability. And if let's say the transmission is not contained, we can compute, we can have simulation on the transmission in that certain company. So you can get this simulator also in the job risk calculator website. And lastly, we also have this simulation, but we don't give the code. We can give the code to you, it's open, but we don't suggest you to just run this on your own, because this should be guided by modelers or experts in this area, because the model is very sensitive to interventions, and you might be misled if you just track the values here. But just to show you, from these simulations that we have done, you can have some values, scenario modeling on what would happen in the future, let's say if you increase the mobility of people through time. And the government already have this for the LGUs. It's called FASTER, but I don't know if that FASTER simulator will be released later in the public, but for now it's being used by LGUs. And to end, I think many people like to see some visualizations to end my sharing of what we have done so far. We are also doing agent-based modeling. So let's say this is for the train MRT, and let's say there's one person here infected inside the MRT, and people can interact, but they have social distancing. Then if they interact, how many people might be infected through time? Okay, so there. But you can also off the interaction. Definitely, if there's no interaction, there will be no other infected people. So yeah, to end my talk, I'm going to reiterate what Dr. Eric have said, that we are one in fighting this COVID-19. The enemy here is the SARS-CoV-2 virus, and we should come hand in hand to cooperate with each other and to cooperate with the government to fight this virus. Thank you very much.
Yeah, thank you, Doc Jomar, for your presentation. Thank you for walking us through on how your team analyzes the data that you get. So, as what Doc Eric mentioned a while ago also, that epidemiology is data-driven. So, of course, it's numbers, and we want to make sense out of this number. So, Doc Jomar, we also would like to request if you could provide us also the link, because I think when we're going through the chat box, a lot are asking for the resource from probably the resources on the links of the dashboard that you just showed us. So we will just collect it from you so that later we can share it to all our participants here at the webinar. So thank you for that presentation, Doc Jomar. So I think we can now ask for another question for Doc Jomar from our participants. Okay, so for Dr. Jomar from Maria Salvacion Esmalia of University of Santo Tomas. So she's asking, how can we ensure that the numerical model related to COVID-19 is accurate and or close to real phenomenon? Of course, given the limits parameter setting, if there are backlogs in our reported cases. And another question probably, how do scientists address this challenge?
Yes, thank you for that question. Definitely, there's no perfect data set, okay? Especially that this is a pandemic, everyone were surprised, and you cannot really get a perfect data set with this time. Okay, even if it's a perfect time, you still can find errors. So scientists and modelers, we have our own way to compute for the error. Okay, so we have an error analysis, and we also calibrate our model depending on the possible situations. Okay, definitely we need to be data driven, evidence based, but also we have our own way to calibrate our model if the data is not perfect. Okay, we have a scientific way to do that. And let's say if there's no data, let's say there's no data, what we can do is we do scenario modeling. Definitely we know some physical mechanisms that are driving the COVID-19 transmission. So we can model that specifically, and from there we do scenario modeling, even if we don't have data. So somehow, what I'm saying here is, of course, it's good to have complete and beautiful and perfect data, but we don't have that. But we have our way to calibrate and do error analysis and do scenario modeling. Modeler actually don't work alone. Also, we collaborate with epidemiologists, and definitely epidemiologists also have their own insights, perspective that can help us even if we don't have data. Thank you.